Hello, my name is Dr. Sunil Gupta and this podcast is on the Handbook of COVID-19 Prevention and Treatment published by Zhejiang University School of Medicine, China on the 18th of March 2020. The handbook is in 3 parts and this podcast covers the first part, which is prevention and control management. The other 2 parts of the handbook, diagnosis and management, and nursing, are covered in subsequent podcasts. First, a disclaimer. This PowerPoint is copied from the Handbook of COVID-19 Prevention and Treatment. It is written to help spread the invaluable experience of healthcare colleagues in China at a time when helpful information is urgently and desperately needed. Understandably, the handbook was written at great speed and there is a possibility there may be some errors and defects. I would strongly recommend that you seek advice from your national professional organisations and the World Health Organization for the latest evidence-based advice. So part 1 of the handbook, which is prevention and control management, is divided into 5 sections. 1. Isolation area management. 2. Staff management. 3. COVID-19 related personal protection management. 4. Hospital practice protocols during COVID-19 epidemic. And 5. Digital support for epidemic prevention and control. So part 1 of the handbook and the first section is isolation area management. And isolation area management is itself subdivided into 1.0 fever clinic, talking about layout, zone arrangements, patient management, screening, admission and exclusion, and 2.0 isolation ward area, talking about scope of application, layout, ward requirements and patient management. 2.0 fever clinic, 1.1 layout of fever clinic. 1. Healthcare facilities shall set up a relatively independent fever clinic, including an exclusive one-way passage at the entrance of the hospital with a visible sign. 2. The movement of people shall follow the principle of 3 zones and 2 passages: a contaminated zone, a potentially contaminated zone, and a clean zone provided and clearly demarcated, and 2 buffer zones between the contaminated zone and the potentially contaminated zone. 3. An independent passage shall be equipped for contaminated items. Set up a visual region for one-way delivery of items from an office area, which is potentially contaminated zone, to an isolation ward, which is the contaminated zone. 1.1 Layout of the fever clinic. Continued. 4. Appropriate procedures shall be standardized for medical personnel to put on and take off their protective equipment. Make flow charts of different zones, provide full-length mirrors, and observe the walking route strictly. 5. Infection prevention and control technicians shall be assigned to supervise the medical personnel on putting on and removing protective equipment so as to prevent contamination. 6. All items in the contaminated zone that have not been disinfected shall not be removed. 1.2 Zone arrangements of fever clinic. 1. Set up an independent examination room, a laboratory, an observation room and a resuscitation room. 2. Set up a pre-examination and triage area to perform preliminary screening of patients. 3. Separate diagnosis and treatment zones. Those patients with an epidemiological history and fever and or respiratory symptoms shall be guided into a suspected COVID-19 patient zone. Those patients with regular fever but no clear epidemiological history shall be guided into a regular fever patient zone. 1.3 Patient Management of Fever Clinic. 1. Patients with fevers must wear surgical masks. 2. Only patients are allowed to enter the waiting area in order to avoid overcrowding. 3. The duration of the patient's visit shall be minimised so as to avoid cross-infections. 4. Educate patients and their families about early identification of symptoms and essential preventative actions. 1.4 Screening, Admission and Exclusion of Fever Clinic. 1. All healthcare workers shall fully understand the epidemiological and clinical features of COVID-19 and screen patients in accordance with the screening criteria below. See Table 1. 2. Nucleic acid tested NAT shall be conducted on those patients who meet the screening criteria for suspected patients. 3. Patients who do not meet the screening criteria above, if they do not have a confirmed epidemiological history but cannot be ruled out from having COVID-19 based on their symptoms, especially through imaging, are recommended for further evaluation and to obtain a comprehensive diagnosis. So carrying on with screening, admission and exclusion. 4. Any patient who tests negative should be retested 24 hours later. If a patient has 2 negative NAT, as in nucleic acid testing results, and negative clinical manifestations from having COVID-19 and discharged from the hospital. If those patients cannot be ruled out from having COVID-19 infections based on their clinical manifestations, they should be subjected to additional NAT tests every 24 hours until they are excluded or confirmed. 5. Those confirmed cases with a positive NAT test shall be admitted and treated collectively based on the severity of their conditions, the general isolation ward or the isolated ICU. Now we come to Table 1, which is screening criteria for suspected COVID-19 cases. So there's epidemiological history and clinical manifestations. So the epidemiological history, and there's 4 possible things. 1. Within 14 days before the onset of the disease, the patient has a travel or residence history in the high-risk regions or countries. 2. Within 14 days before the onset of the disease, the patient has a history of contact with those infected with SARS-CoV-2, those with a positive NAT test. 3. Within 14 days before the onset of the disease, the patient had direct contact with patients with fever or respiratory symptoms in high-risk regions or countries. 4. Disease clustering, i.e. 2 or more cases with fever and or respiratory symptoms occur at such places as homes, offices, schools, classrooms, etc. within 2 weeks. So that's the epidemiological history. Then the clinical manifestations are: 1. The patient has a fever and or respiratory symptoms. 2. The patient has the following CT imaging features of COVID-19. Multiple patchy shadows and interstitial changes occur early, particularly at the lung periphery. The conditions further develop into multiple ground glass opacities and infiltrates in both lungs. In severe cases, the patient may have lung consolidation and rarely pleural effusion. 3. The white blood cell count in the early stage of the disease is normal or decreased, or the lymphocyte count decreases over time. So if the patient meets 1 epidemiological history and 2 clinical manifestations, then that's yes. If the patient has no epidemiological history and meets 3 clinical manifestations, the answer is yes. But if the patient has no epidemiological history and meets 1 to 2 clinical manifestations but cannot be excluded from COVID-19 through imaging, then the way forward is expert consultation. 2.0 Isolation Ward Area. 2.1 Scope of Application. The isolation ward area includes an observation ward area, isolation wards, and an isolation ICU area. The building layout and workflow shall meet the relevant requirements of the hospital isolation technical regulations. Medical providers with negative pressure rooms shall implement standardized management in accordance with relevant requirements. Strictly limit access to isolation wards. 2.2 Layout of isolation ward areas. Please refer to the fever clinic. 2.3 Ward requirements of isolation ward area. 1. Suspected and confirmed patients shall be separated in different ward areas. 2. Suspected patients shall be isolated in separate single rooms. Each room shall be equipped with facilities such as a private bathroom, and the patient's activities should be confined to the isolation ward. 3. Confirmed patients can be arranged in the same room with bed spacing of not less than 1.2 metres, approximately 4 feet. The room should be equipped with facilities such as a bathroom, and the patient's activity must be confined to the isolation ward. 2.4 Patient management of isolation ward. 1. Family visits and nursing shall be declined. Patients should be allowed to have their electronic communication devices to facilitate interaction with loved ones. 2. Educate patients to help them prevent further spread of COVID-19 and provide instructions on how to wear surgical masks, proper hand washing, cough, medical observation and home quarantine. So we now come on to section 2, which is staff management, which is divided into 1.0 workforce management and 2.0 health management. 1.0 workforce management. 1. Before working in a clinic and isolation ward, the staff must undergo strict training and examinations to ensure that they know how to pass or put on and remove personal protective equipment. They must pass such examinations before being allowed to work in these wards. 2. The staff should be divided into different teams. Each team should be limited to a maximum of 4 hours of work in an isolation ward. The team shall work in the isolation wards, contaminated zones, at different times. 3. Arrange treatment, examination and disinfection for each team as a group to reduce the frequency of staff moving in and out of the isolation wards. 4. Before going off duty, staff must wash themselves and conduct necessary personal hygiene regimes to prevent possible infection of their respiratory tracts and mucosa. 2.0 Health management. 1. The frontline staff in the isolation areas, including healthcare personnel, medical technicians and property and logistics personnel, shall live in an isolation accommodation and shall not go out without permission. 2. A nutritious diet should be provided to improve the immunity of medical personnel. 3. Monitor and record the health status of all staff on the job and conduct health monitoring for frontline staff, including monitoring body temperature and respiratory symptoms. Help address any psychological and physical problems that arise from relevant experts. Carrying on with health management. 4. If the staff have any relevant symptoms such as fever, they should be isolated immediately and screened with an NAT. 5. When the frontline staff, including healthcare personnel, medical technicians and property and logistic personnel, finish their work in the isolation area and are returning to normal life, they shall first be NAT tested for SARS-CoV-2. If negative, they should be isolated collectively at a specified area for 14 days before being discharged from medical observation. So we now come to the third section, which is COVID-19 related personal protection management. So there's 3 levels of protection: level 1, level 2 and level 3. So level 1 protection, the protective equipment is disposable surgical cap, disposable surgical mask, work uniform, disposable latex gloves and or disposable isolation clothing if necessary. And the scope of application of Level 1 protection is pre-examination, triage and general outpatient department. Level 2 protection. The protective equipment is disposable surgical cap, medical protective mask N95, work uniform, disposable medical protective uniform, disposable latex gloves and goggles. And the scope of application of Level 2 protection is fever outpatient department, isolation ward area including the isolated intensive ICU, non-respiratory specimen examination of suspected stroke confirmed patients, imaging examination of suspected stroke confirmed patients, and cleaning of surgical instruments used with suspected stroke confirmed patients. Then there's Level 3 protection, and the protective equipment is disposable surgical cap, medical protective mask N95, work uniform, disposable medical protective uniform, disposable latex gloves, full face respiratory protective devices or powered air purifying respirator. And the scope of application for Level 3 protection is when the staff performs operations such as tracheal intubation, tracheostomy, bronchofibroscopy, gastroenterological endoscopy, etc., during which the suspected stroke confirmed patients may spray or splash respiratory secretions or body fluid stroke blood. The other scope of application of Level 3 protection is when the staff performs surgery and autopsy for confirmed stroke suspected patients and when the staff carry out NAT for COVID-19. So the notes to do with this table are: all staff at healthcare facilities must wear medical surgical masks. All staff working in the emergency department, outpatient departments of infectious diseases, outpatient departments of respiratory care, departments of stomatology or endoscopic examination rooms such as gastrointestinal endoscopy, bronchofibroscopy, laryngoscopy, etc. must upgrade their surgical mask to medical protective mask N95 based on Level 1 protection. And the third note is staff must wear a protective face screen based on Level 2 protection whilst collecting respiratory samples from suspected stroke confirmed patients. We now come on to Section 4, which is Hospital Patient Protocols during COVID-19 epidemic. And this is divided into 9 sections. So Section 1.0, Guidance on donning and removing personal protective equipment PPE to manage COVID-19 patients. 2.0 is disinfection procedures for COVID-19 isolated ward area, which is divided into 2.1 disinfection for floor and walls, 2.2 disinfection of object surfaces, 2.3 air disinfection, 2.4 disposal of fecal matter and sewage. Then there's 3.0 disposal procedures for spills of COVID-19 patient fluid stroke bloods, which is divided into 3.1 for spills of a small volume less than 10 millilitres of blood stroke bodily fluids, and 3.2 for spills of a large volume greater than 10 millilitres of blood and bodily fluids. So carrying on, 4.0 is disinfection of COVID-19 related reusable medical devices, which is divided into 4.1 disinfection of powered air purifying respirator, 4.2 cleaning and disinfection procedures for digestive, endoscopy and bronchofibroscopy, 4.3 pre-treatment of other reusable medical devices, 5.0 disinfection procedures for infectious fabrics of suspected or confirmed patients, and that's divided into 5.1 infectious fabrics, 5.2 collection methods, 5.3 storage and washing, and 5.4 disinfection of transport tools. So carrying on with the hospital practice protocols during COVID-19 epidemic with 6.0 disposable procedures for COVID-19 related medical waste, 7.0 procedures for taking remedial actions against occupational exposure to COVID-19, 8.0 surgical operations for suspected or confirmed patients, which is divided into 8.1 requirements for operation rooms and staff PPE, and 8.2 procedures for final disinfection, and 9.0 procedures for handling bodies of deceased, suspected or confirmed patients. So there's now a diagram on guidance on donning and removing personal protective equipment, PPE, to manage COVID-19 patients. And obviously you have to look at the diagram. So first, put on special work clothes and work shoes. 2, wash hands. 3, put on a disposable surgical cap. 4, put on a medical protective mask N95. 5, put on inner disposable nitrile / latex gloves. 6, put on goggles and protective clothing. 7, put on disposable latex gloves. And then the donning is complete. So the protocol for donning PPE: put on special work clothes and work shoes, wash hands, put on disposable surgical cap, put on medical protective mask N95, put on inner disposable nitrile / latex gloves, put on goggles and protective clothing. Note, if wearing protective clothing without foot covers, please also put on separate waterproof boot covers. Put on disposable isolation gown if required in the specific work zone, and face shield / powered air purifying respirator if required in the specific work zone, and then put on outer disposable latex gloves. We then come to a diagram about the protocol for removing PPE, and you start off with 1, replace the outer gloves with new ones, wash hands. 2, remove protective clothing along with outer glove, wash hands. 3, remove goggles, wash hands. 4, remove mask, wash hands. 5, remove cap, wash hands. 6, remove inner disposable latex gloves. 7, removal completed. So the protocol for removing PPE: wash hands and remove visible bodily fluid / blood contaminants on the outer surfaces of both hands. Wash hands, replace outer gloves with new gloves. Remove powered air purifying respirator or self-priming filter type full face mask / mask if used. Wash hands. Remove disposable gowns along with outer gloves if used. Wash hands and put on outer gloves. Enter removal area number 1. Wash hands and remove protective clothing along with outer gloves. For gloves and protective clothing, turn inside out while rolling them down. Note, if used, remove the waterproof boot covers with clothing. Wash hands. Remove number 2. Wash hands and remove goggles. Wash hands and remove masks. Wash hands and remove cap. Wash hands and remove inner disposable latex gloves. Wash hands and leave removal area number 2. Wash hands, take a shower, put on clean clothes and enter the clean area. We now come on to 2.0 disinfection procedures for COVID-19 isolation ward areas. 2.1 disinfection for floor and walls. 1. Visible pollutants shall be completely removed before disinfection and handled in accordance with disposable procedures of blood and bodily fluid spills. 2. Disinfect the floor and walls with 1,000 milligrams per litre chlorine-containing disinfectant through floor mopping, spraying or wiping. 3. Make sure that disinfection is conducted for at least 30 minutes. 4. Carry out disinfection 3 times a day and repeat the procedure at any time when there is contamination. 2.2 Disinfection of Object Surfaces. 1. Visible pollutants should be completely removed before disinfection and handled in accordance with disposable procedures of blood and bodily fluid spills. 2. Wipe the surfaces of objects with 1,000 milligrams per litre chlorine-containing disinfectant or wipes with effective chlorine. Wait for 30 minutes and then rinse with clean water. Perform disinfection procedure 3 times a day. Repeat at any time when contamination is suspected. 3. Wipe cleaner regions first, then more contaminated regions. First wipe the object surfaces that are not frequently touched, then wipe the object surfaces that are frequently touched. Once an object surface is wiped clean, replace the used wipe with a new one. We now come to 2.3, ear disinfection. 1. Plasma ear sterilizers can be used and continuously run for ear disinfection in an environment with human activity. 2. If there are no plasma ear sterilizers, use ultraviolet lamps for 1 hour each time. Perform this operation 3 times a day. 2.4, disposal of fecal matter and sewage. 1. Before being discharged into the municipal drainage system, fecal matter and sewage must be disinfected by treating with chlorine-containing disinfectant. For the initial treatment, the active chlorine must be more than 40 milligrams per litre. Make sure the disinfection time is at least 1.5 hours. 2. The concentration of total residual chlorine in the disinfected sewage should reach 10 milligrams per litre. Now we come to 3.0, disposal procedures for spills of COVID-19 patient blood-stroke fluids, starting with 3.1 for spills of a small volume, i.e. less than 10 millilitres of blood-stroke bodily fluids. 1. Option 1. The spill should be covered with chlorine-containing disinfecting wipes containing 5,000 milligrams per litre effective chlorine and carefully removed. Then the surfaces of the object should be wiped twice with chlorine-containing disinfection wipes containing 500 milligrams per litre effective chlorine. 2. Option 2. Carefully remove the spills with disposable absorbent materials such as gauze, wipes, etc., which have been soaked in 5,000 milligrams per litre chlorine-containing disinfecting solution. So now come to 3.2 for spills of a large volume greater than 10 millilitres of blood and bodily fluids. 1. First, place signs to indicate the presence of a spill. 2. Perform disposal procedures according to option 1 or option 2 described below. So option 1 is you absorb the spilled fluids for 30 minutes with a clean absorbent towel containing peroxyacetic acid that can absorb up to 1 litre of liquid per towel, and then clean the contaminated area after removing the pollutants. Option 2, completely cover the spill with disinfectant powder or bleach powder containing water-absorbent ingredients, or completely cover it with disposable water-absorbing materials and then pour a sufficient amount of 10,000 milligrams per litre chlorine-containing disinfectant onto the water-absorbing material, or cover with a dry towel which will be subjected to high-level disinfection. Leave for at least 30 minutes before carefully removing the spill. 3. Fecal matter, secretions, vomit, etc. from patients shall be collected into special containers and disinfected for 2 hours by a 20,000 milligram per litre chlorine-containing disinfectant at a spill to disinfectant ratio of 1 to 2. 4. After removing the spills, disinfect the surfaces of the polluted environment or objects. 5. The containers that hold the contaminants can be soaked and disinfected with 5,000 milligrams per litre active chlorine-containing disinfectant for 30 minutes and then cleaned. 6. The collected pollutants should be disposed of as medical waste. 7. The used items should be put into a double-layer medical waste bags and disposed of as medical waste. We now come on to Section 4, Disinfection of COVID-19 related reusable medical devices. 4.1, Disinfection of powered air purifying respirator. So you've got the powered air purifying respirator, which is made up of a hood, motor and strap, a battery surface, a particulate filter box and a breathing tubes. So for the motor and strap and battery surface, you repeatedly wipe them with 1,000 milligram per litre chlorine-containing disinfectant and let the disinfectant work for 30 minutes. And for the particulate filter box, you do not detach the filter box and you repeatedly wipe them with 1,000 milligram per litre chlorine-containing disinfectant and let the disinfectant work for 30 minutes. So once you've done that for all three of motor and strap, battery surface and particulate filter box, you wipe all parts repeatedly and evenly with a soft cloth dipped in the cleaning liquid, i.e. clean water. You then let the parts dry and place them in a Ziploc bag for future use. Note, do not let liquid enter the main unit ear outlet or motor. Please be careful when wiping the battery contacts located at the bottom of the motor. Do not touch the battery contacts directly. Please make sure this part is completely dry before next use or storage, and do not touch the filter element when cleaning the outer surface. Replace the filter element according to the product's instructions. For the breathing tube, you soak in 1,000 milligrams per litre chlorine-containing disinfectant for 30 minutes. Then you wash it with clean water and you let the parts dry and place them in a Ziploc bag for future use. And the other thing about this disinfection of the powered air purifying respirator is the disinfection procedures for protective hood described above are only for reusable protective hoods, excluding disposable protective hoods. We now come to 4.2, cleaning and disinfection procedures for digestive endoscopy and bronchofibroscopy. 1. Soak the endoscope and reusable valves in 0.23% peroxyacetic acid. Confirm the concentration of the disinfectant before use to make sure it will be effective. 2. Connect the perfusion line of each channel of the endoscope. Inject 0.23% peroxyacetic acid liquid into the line with a 50 ml syringe until fully filled and wait for 5 minutes. 3. Detach the perfusion line and wash each cavity and valve of the endoscope with a disposable special cleaning brush. 4. Put the valves into an ultrasonic oscillator containing enzyme to oscillate it. Connect the perfusion line of each channel with the endoscope. Inject 0.3% peroxyacetic acid into the line with a 50 ml syringe and flush the line continuously for 5 minutes. Inject air to dry it for 1 minute. 5. Inject clean water into the line with a 50 ml syringe and flush the line continuously for 3 minutes. Inject air to dry it for 1 minute. 6. Perform a leakage test on the endoscope. We now come on to 4.2, cleaning and disinfection procedures for digestive endoscopy and bronchofibroscopy. So 7, put an automatic endoscopic washing and disinfection machine. Set up a high level of disinfection for treatment. 8, send the devices to the disinfection supply centre to undergo sterilisation with ethylene oxide. 4.3, pre-treatment of other reusable medications. We now come on to section 5.0, disinfection procedures for infectious fabrics of suspected or confirmed patients. 5.1, infectious fabrics. 1. Clothes, bed sheets, bed covers and pillowcases used by patients. 2. Ward area bed curtains. 3. Floor towels used for environmental cleaning. 5.2, collection methods. 1. First, pack the fabrics into a disposable, water-soluble plastic bag and seal the bag with matching cable ties. 2. Then pack the bag into another plastic bag, seal the bag with cable ties in a gooseneck fashion. 3. Finally, pack the plastic bag into a yellow fabric bag and seal the bag with cable ties. 4. Attach a special infection label and the department name. Send the bag to the laundry room. 5.3 Storage and washing. 1. Infectious fabrics should be separated from other infectious fabrics, i.e. non-COVID-19 patients, and washed in a dedicated washing machine. 2. Wash and disinfect these fabrics with chlorine-containing disinfectant at 90 degrees Celsius for at least 30 minutes. Disinfection of transport tools. 1. Special transport tools should be used specifically for transporting infectious fabrics. 2. The tools should be disinfected immediately each time after being used for transporting infectious fabrics. 3. The transport tools should be wiped with chlorine-containing disinfectant with 1000 milligrams per litre active chlorine. Leave disinfectant for 30 minutes before wiping the tools clean with clean water. We now come on to section 6.0, disposable procedures for COVID-19 related medical waste. 1. All waste generated from suspected or confirmed patients should be disposed of as medical waste. 2. Put the medical waste into a double-layer medical waste bag, seal the bag with cable ties in a gooseneck fashion and spray the bag with 1000 milligrams per litre chlorine-containing disinfectant. 3. Put sharp objects into a special plastic box, seal the box and spray the box with 1000 milligrams per litre chlorine-containing disinfectant. 4. Put the bagged waste into a medical waste transfer box, attach a special infection label, fully enclose the box and transfer it. 5. Transfer the waste to a temporary storage point for medical waste along a specified route at a fixed time point and store the waste separately at a fixed location. 6. The medical waste shall be collected and disposed of by an approved medical waste disposal provider. Now come on to section 7.0, procedures for taking remedial action against occupational exposure to COVID-19. 1. Skin exposure. Skin is directly contaminated by a large amount of visible bodily fluids, blood, secretions or fecal matter from the patient. So this is the kind of procedures to take. So we'll talk about skin exposure. So mucous membrane exposure is where the mucous membranes such as the eyes and respiratory tract are directly contaminated by visible bodily fluids, blood, secretions or fecal matter from the patients. A sharp object injury is where there's the piercing of the body by sharp objects that were directly exposed to the patient's bodily fluids, blood, secretions or fecal matter. And direct exposure to the respiratory tract means falling off a mask, exposing the mouth or nose to a confirmed patient 1 metre away or less who is not wearing a mask. So the procedures to take for taking remedial action against occupational exposure to COVID-19. So depending on what the occurrence of the COVID-19 related occupational exposure is. So if it's been intact skin exposure or damaged skin exposure, the course of action is to remove the contaminants with clean tissues or gauze, then apply 0.5% iodophor or 75% alcohol to the skin and let the solution sit for at least 3 minutes for disinfection, thoroughly flush with running water. If it's exposure of the mucous membrane such as the eyes, then the answer is to flush with plenty of normal saline or 0.05% iodophor for disinfection. If it's a sharp object injury, then the answer is to squeeze blood out from proximal end to distal end, flush the wound with running water, disinfect with 70% alcohol, 0.5% iodophor. And if it's a direct exposure of respiratory tract, the answer is immediately leave the isolation area. Gargle with plenty of normal saline or 0.05% iodophor. Dip a cotton swab with 75% alcohol and wipe in a circular motion the nasal cavity gently. So for all of these things, once you've done the things which are particular to the exposure, you then evacuate from the isolation area and enter the designated isolation room. You then report to the relevant departments and you then isolate and observe people with exposures other than intact skin exposure for 14 days. In case of symptoms, report to the relevant department in a timely manner. We now come on to section 8.0, surgical operations for suspected or confirmed patients. 8.1, requirements for operation rooms and staff PPE. 1. Arrange the patient in a negative pressure operating room. Verify the temperature, humidity and air pressure in the operation room. 2. Prepare all required items for the operation and use disposable surgical items if possible. 3. All surgical personnel, including surgeons, anaesthetists, hand-washing nurses and charge nurses in the operating room, should put on their PPE in the buffer room before entering the operating room. Put on double caps, medical protection mask N95, medical goggles, medical protective clothing, boot covers, latex gloves and powered air purifying respirator. 4. The surgeons and the hand-washing nurses shall wear disposable sterile operating gloves and sterile gloves in addition to the PPE as mentioned above. 5. Patients should wear disposable caps and the disposable surgical masks according to their situation. 6. The charge nurses in the buffer room are responsible for delivering items from the buffer area to the negative pressure operating room. 7. During the operation, the buffer room and the operating room shall be tightly closed, and the operation must be carried out only if the operation room is under negative pressure. 8. Irrelevant personnel shall be excluded from entering the operating room. (8.2) Procedures for final disinfection. 1. Medical waste shall be disposed of as COVID-19 related medical waste. 2. Reusable medical devices shall be disinfected according to the disinfection procedures of SARS-CoV-2 related reusable medical devices. 3. Medical fabrics shall be disinfected and disposed of according to the disinfection procedures for SARS-CoV-2 related infectious fabrics. 4. Surfaces of objects, i.e. instruments and devices including device table, operating bed, etc. 1. Visible blood-stroke bodily fluids contaminants shall be completely removed before disinfection, handled in accordance with disposable procedures of blood and bodily fluid spills. 2. All surfaces shall be wiped with a disinfectant containing 1000 mg per litre active chlorine and allowed to sit for 30 minutes with the disinfectant. 5. For floors and walls, 1. Visible blood-stroke bodily fluid pollutants should be completely removed before disinfection, handled in accordance with disposable procedures of blood and bodily fluid spills. 2. All surfaces should be wiped with a disinfectant containing 1000 mg per litre active chlorine and allowed to sit for 30 minutes with the disinfectant. 6. Indoor air, turn off the fan filter unit. Disinfect the air by radiation by ultraviolet lamp for at least 1 hour. Turn on the fan filter unit to purify the air automatically for at least 2 hours. Now come on to section 9.0, procedures for handling bodies of deceased, suspected or confirmed patients. 1. Staff PPE. The staff must make sure that they are fully protected by wearing work clothes, disposable surgical caps, disposable gloves and thick rubber gloves with long sleeves, medical disposable protective clothing, medical protective masks N95 or powered air purifying respirators, protective face shields, work shoes or rubber boots, waterproof boot covers, waterproof aprons or waterproof isolation gowns, etc. Number 2, corpse care. Fill all openings or wounds the patients may have, such as mouth, nose, ears, anus and tracheostomy openings, by using cotton balls or gauze dipped in 3000 to 5000 mg per litre chlorine-containing disinfectant or 0.5% peroxyacetic acid. 3. Wrapping. Wrap the corpse with a double-layer cloth sheet soaked with disinfectant and pack it into a double-layer sealed leak-proof corpse wrapping sheet soaked with chlorine-containing disinfectant. Section 9. Procedures for handling bodies of deceased, suspected or confirmed patients. Continued. 4. The patient should be transferred by the staff in the isolation ward of the hospital via the contaminated area to the special elevator out of the ward and then directly transported to a specified location for cremation by a special vehicle as soon as possible. 5. Final disinfection. Perform final disinfection of the ward and the elevator. So we now come on to the 5th section of part 1 of the handbook, which is digital support for epidemic prevention and control, which is divided into 1.0, reduce the risk of cross-infection when patients seek medical care. 2, lower work intensity and the infection risk of medical personnel. 3, rapid response to emergency needs of COVID-19 containment. 1.0, reducing the risk of cross-infection when patients seek medical care. 1. Guide the public to get access to non-emergency services such as chronic disease treatment online so as to decrease the number of visitors in healthcare facilities. Doing so minimises the risk of cross-infection. 2. Doctors who must visit healthcare facilities should make an appointment through other means. Patients who must visit healthcare facilities should make an appointment through other means, including internet portals which provide necessary guidance in transportation, parking, arrival time, protective measures, triage information, indoor navigation, etc. Collect comprehensive information online by patients in advance to improve the efficiency of diagnosis and treatment and limit the duration of the patient's visit. 3. Encourage patients to take full advantage of digital self-service devices to avoid contact with others so as to lower the risk of cross-infections. 2.0, lower work intensity and infection risk of medical personnel. 1. Collect shared knowledge and experience of experts through remote consultation and multidisciplinary MDT team to offer the optimum therapeutics for difficult and complicated cases. 2. Take mobile and remote rounds to lower unnecessary exposure risk and work intensity of medical personnel while saving protective supplies. 3. Access the patient's latest health conditions electronically through health QR codes. Note, everyone is required to obtain a green code through the health QR system to travel around the city, and online epidemiological questionnaires in advance to provide triage guidance to the patients, especially those with fever or suspected cases, while effectively preventing the risk of infections. 4. Electronic health records of patients in fever clinics and the CT imaging AI system for COVID-19 can help reduce the work intensity, quickly identify highly suspected cases and avoid misdiagnosis. Now we come to 3.0, rapid response to emergency needs of COVID-19 containment. 1. Basic digital resources required by a cloud-based hospital system allows for immediate usage of the information systems needed for emergency response to the epidemic, such as the digital systems equipped for newly established fever clinics, fever observation rooms and isolation wards. 2. Utilise the hospital information system based on the internet infrastructure frame to conduct online training for healthcare workers and one-click deployment system, and to facilitate the operation and support engineers to perform remote maintenance and new functions update for medical care. And then this slide is about the model for online healthcare, which is relevant to people in China, and there's some more information about that as well. So in summary, this presentation was on part 1 of the handbook, which is on prevention and control management of COVID-19. It discussed isolation area management, staff management, COVID-19 related personal protection management, hospital practice protocols during COVID-19 epidemic, and digital support for epidemic prevention and control. And please see the second and third podcast, the second one which will be on diagnosis and treatment, and the third one which will be nursing. But I would strongly recommend that you go to the handbook itself for the latest information. Thank you very much.